Today we'll see spirochetes. Spirochetes. What are spirochetes? Spirochetes are spiral coil-like organism and chete means hair. So they are large, motile, flexible, slender and they are helical organisms. The cell wall, it shares many properties with the gram-negative bacteria. They are motile and they are of three types. So what are the types of motility by the spirochetes? They are corkscrew type of motility, flexion and extension, translatory motion, and we have this these are the various families, that is spirochetes. So spirochetes, which includes Treponema, Borrelia, Leptospiraceae, in the family which includes Leptospira. So this is a endoflagella where you can see it extends along the protoplasmic layer, that is in the cell wall. It is embedded, the endoflagella is embedded in the cell wall. So in this spirochetes, we'll see about the Treponema. So Treponema, it includes the major, it includes 4 pathogenic and 6 human non-pathogenic species. So Treponema pallidum was discovered by Shorden and Hoffman in 1905. And this Treponema pallidum consists of 3 subspecies: Treponema pallidum, subspecies pallidum, Treponema pallidum, subspecies endemicum, and Treponema pallidum, subspecies pertenu, which causes yaws, whereas Treponema pallidum subspecies endemicum, it causes endemic syphilis, that is Vigel, and Treponema pallidum subspecies pallidum, which causes syphilis. So Treponema cariaceum, it causes gel, yaws, and pinta. See, these are the non-venereal disease. So these pathogenic treponemes are found in the lesions of trypanomatosis. So some of them, they can be the commensals, which is found in the mouth and in the genital tract. They are shorter and thicker than that of Treponema pallidum. So we'll see the morphology. So the morphology, they are slender, corkscrew, filamentous helices. So they are about 6 to 14 micrometer and they have equally spaced coils and they are actively motile and they have the rotating steadily above the long axis. So because of this very thin structure, we cannot see with the PET film. So we have to look only through the dark field microscope. So we can stain using the silver impregnation technique by using Fontana staining, where you can see the very thin coils. So how can you cultivate these treponemes? So like the other organism, it's very difficult for the growth. They have limited growth of this treponema. So usually you can use some animal inoculation where you can grow in the testicle of rabbit. So Treponema pallidum, they grow only in the tissue cultures of rabbit epithelial cells. So either you can use the cells for the generation. So based on this, these organism can be used for this diagnostic purposes for the specific type of test where we separate the antigens. So what are the pathogenic determinants? So the pathogenic determinants, they are the outer membrane protein. So they have the ability of the organism to adhere to the host cells. Then hyaluronidase, which is produced by virulent spirochetes, so which may facilitate this perivascular infiltration. And other features includes host cell fibronectin. Say they'll protect the organism against phagocytosis and the attachment of the organism to the host cells by absorption of the fibronectin to the organism. So now we'll see about the syphilis. So if you see syphilis, so there are various stages of syphilis. So it's basically a venereal disease. So how it is acquired? So adult syphilis is acquired by sexual contact, and usually these organisms they penetrate through the mucosal surfaces or the abraded skin, and they travel to the site of from the skin they travel from the site of infection under the skin. So then they drain into the lymph nodes. So the incubation period, if you see, it is about 9 to 90 days. It will take a longer period of incubation. And the other lesion which is following this are endarteritis. So there can be some extensive inflammation of the and necrosis of the tissues. So what are the various stages of syphilis? If you see the various stages of syphilis, they are primary syphilis, secondary to syphilis, then you have the latent syphilis and the tertiary syphilis. So what is this primary syphilis? So primary syphilis is when we get the infection by the venereal contact. So the infection is spread only through the skin, that is through any abrasions, and it can occur only in the genital areas or the areas where the skin is exposed. Either it can be in the hand, in the lips, or in the nipples. So these are the areas where you can get the lesions. Okay, and then if you see the secondary syphilis, this lesions they will heal. It will take around a month for the lesions to heal, and then the patients enter into the secondary stage of syphilis. So in secondary syphilis, what will happen? There will not be any lesions, but this primary chancre-like lesions, but there will be maculocutaneous rashes all over the body. And for this rashes and other additive symptoms can be seen. For this only the patient will be coming to the doctor. Otherwise, in primary syphilis, it is self-healing, and so you cannot see most of the cases of primary syphilis. Then after this will take some years. It will take some 2 to 3 years. Then after that, the patient enters into the latent stage where you cannot see any much infection. Then the tertiary syphilis, where you can see the other complications of syphilis. There can be syphilitic aneurysm, then tabes dorsalis, then general paralysis of insane, and these are the other features. So as I told you, the main source of infection is by sexual contact, and it can be by transplacental to the babies. Okay, so it results in congenital syphilis. So the hospital personnel can also get infected by means of direct contact or this improper handling of the samples, or it can be from a blood transfusion. So as I told you, in the pathogenicity, the primary syphilis, primary stage, so the papule occurs 2 to 4 weeks after initial exposure of the infection, and the patient will present with a hard chancre. So the syphilis it's contacted by from into the medical personnel through non-venereal route by it can be because of the occupational hazard, and it will heal spontaneously, leaving a very thin scar. So this is a primary syphilis where you can see the chancre in the lip. Then in the secondary stage, where you can see the when the primary chancre that is heals, there will be this chancre. If you see, this is a painless ulcer, so there will not be pain. So it's a shiny, painless papule. Okay, it's a raised lesion. And in the secondary stage, it starts to manifest only 3 to 8 weeks after the primary chancre heals. And here you can see other systemic manifestations also. So where there will be low-grade fever, then malaise, lymphadenopathy, mucocutaneous eruptions, then rashes. They are seen all over the skin. That is the maculopapular rashes will be seen. So 13 to 15% if you treat them, if you untreat, if you're not getting treated also, they will enter into the other stages of syphilis. That is the latent stage and the tertiary stage. So in the latent stage, if you see it's a dormant stage, so there will not be much clinical symptoms here. So it will be taking some years. It will take at least 2 years. And in the tertiary stage, which is this is the last stage of stiffness, where it can take up to a decade or so after the primary lesions. So this tertiary lesions, that is here you will not find any lesions. You can find necrotic lesions sometimes, which is irreversible, and then blindness can be seen. Then musculoskeletal diseases like your general, tabes dorsalis, general paralysis of insane, and resorption of the bones. And these are the irreversible aneurysms, syphilitic aneurysms. These are the things which we can expect in the late tertiary stages of syphilis. So there is syphilitic gammata. So this is usually seen in children also. In congenital syphilis, you can how it occurs. So it occurs when it crosses when the if you see the infection, it causes the blood placental barrier after about 16 week of gestation, and it can result in stillbirth. So in the latent infection, usually the patient is seropositive. In the early infection, the manifestation occurs within 2 years, the second year, and there can be severe rhinitis. That is, it is called as snuffles. So later there can be bony destructions, and typical syphilitic facies of the children can occur. So there can be notched teeth, then interstitial keratitis. So then there can be deafness, which is due to the eighth nerve destruction. But these can be prevented by a proper antenatal care when it is given. That is, that's why you have to treat the syphilis patients. We have to detect the patients as early as possible. So that's why it is one of the important tests which we do during the first antenatal visit, so that we can treat the mother, so that you can prevent all this type of this congenital syphilis in children. So either the patient can result in stillbirth, or if it is born, it can be with all this syphilitic stigmata. So this is syphilitic chorioretinitis. Syphilitic facies, where there is resorption of the bones. So these are the latent tertiary type stages. It's Hutchinson's teeth, so where there is a destruction of the eruption of teeth. So how will you diagnose syphilis? So in the primary stage of syphilis, you can diagnose it by their direct dark field microscope. So the dark field microscope, basically you take the specimen from the exudate which comes out from the chancre. So it is a painless chancre. So you will have a glary exudate which comes from the chancre, that you have to take it on a glass slide. After you wipe it with the warm cotton with the saline, and you have to take the exudate, put it on a slide, and you have to look for the movement, that is the corkscrew type of motility should be seen with the dark field microscope. So you can also do direct immunofluorescence, and then Fontana staining can be done. But that is a silver impregnation technique where you can demonstrate it. Then other tissue staining can be the libardity stain. So what are the serological tests you will do for syphilis? So the serological test which we do for syphilis is VDRL test. So what is VDRL test? VDRL is Venereal Disease Research Laboratory Test. So in this test, basically what do we do? So what type of test is VDRL test? So VDRL test is it's a slide flocculation test. So we are going to take the patient's antibody and we are going to test it. So we have to get us some antigen. So it is very difficult to culture your syphilis, your organism. So what we have to do is we have to take some antigen. So here we are taking the cardiolipin antigen. So cardiolipin antigen is basically obtained from it's a lecithin, cholesterol, and it's an extract from the beef heart. Okay, and that extract we have to add it, and then we have to look for the flocculation whether it occurs or not. For this we have to look under the microscope to look for the any flocculation. So we do, if suppose if it comes as positive, we just do in titers and we tell it as 1 in 4 or 1 in 8. It's a doubling dilution of the titers. So 1 in 4 or 1 in 8. So these are the titers which we do. And then this we take from the patient serum. So this same principle we are applying for RPR. So RPR is rapid plasma reagent test. So this is a slide agglutination. It's a passive agglutination test. Here we are converting this precipitation into agglutination by using a carrier particle. So what is a carrier particle we are using? So here we will be using the carbon particle. So carbon particle will be coated with so carbon particle will be coated with the antigen, and we are using the anti-serum. So when we mix both together, then we will be looking for the agglutination whether it is occurring. So similarly, we use this Wassermann test also. So basically, which is with RPR test will be of much simplified. It's a simplified test. So yeah, inactivation of the serum should be done in VDRL test at 56 degrees Celsius for at least half an hour. But for RPR test, we need not do it. Okay. So, and similarly, CSF can be directly done, tested for VDRL test, and RPR test we need not, we cannot do your CSF testing. So why do you do this titers? Titers basically why we do is to check whether the treatment is acting or not. So if the patient is having 1:16 titer, after treating, you can look for whether the titer is decreasing or not. So these are the non-specific tests because we are using the reagent antigen. Okay. So reagent antigen only I told you it's a cardiolipin and cholesterol, lecithin and cholesterol. And here in so once here, what is the disadvantage of this non-specific test is there can be some false positive reaction. So some patients can be having some other inflammatory reactions. So it can be a acute disease or it can be a chronic disease. So acute disease can be acute tissue injuries or acute some other infections. So that will be giving positive in case of your reagent, your non-specific test. Whereas in your specific test, we can rule out this. Or some chronic inflammations like your collagen vascular diseases. So in these cases also you will be seeing false positive test. So for this we have to do some specific test. So for that the gold standard for the specific test is treponema pallidum immobilization test. So in treponema pallidum immobilization test, basically what we do is we take a treponema pallidum that is the patient the grown antigen that is from the cultures whatever organism we grow, so that we take under the dark field microscope and then we add the patient serum. So once we add the patient serum, what will happen, this antigen will go and bind, antibody will go and bind to the antigen and make it immotile. So that is called as immobilization test. So treponema pallidum immobilization test. Then we have this fluorescent treponema pallidum antibody absorption test. So here what we do is, here you can use even here in the immobilization test we need a live treponem, whereas here treponema pallidum need not be live. So this we have to add. So this we have to just add the fluorescent dye along with the antigen. We just take it and then we add the antibody. So once the antigen antibody reaction it goes and binds, there will be having the fluorescence. So this is fluorescent treponemer antibody absorption test. Then we have this hemoagglutination test. So TPHA, that is treponemer pallidum heme absorption test. Here we take the washed erythrocytes. So this rabbit or sheep erythrocytes can be taken. So this has to be coated with the antigen, that is treponema antigen, and then we add the patient serum. So once this antigen antibody reaction occur, we will be looking for the agglutination of the erythrocytes. So this you can look at in a microtiter plate and we can titrate it. So this is your hemoagglutination test. Okay, so basically we have specific and non-specific test. So we are doing only the non-specific test first, and for confirmation only we do the specific test, which is treponema pallidum immobilization test, fluorescent treponema pallidum antibody absorption test, then treponema pallidum hemoagglutination assay. So these are the various tests which we do. So already I explained to you what is VDRL. So and then rapid plasma reagent, and you also have this toluidine red unheated serum test. So this is also a trust. This is also the another test which we use as a flocculation test. And then complement fixation test. It's a Wasserman's test. Okay. So basically we do only the RPR, which is widely used. So VDRL test is a slide flocculation test. RPR test is a, what type of test it is? So RPR is a slide agglutination test. So for the specific test, what we use is, we use this Nicole strain of treponema pallidum. So these are the it can be extracts. Okay. So for this FTABS, for fluorescent treponema pallidum antibody absorption test, we use this Reader's treponeme. Okay. And microagglutination test, we use this Nicole strain. Then treponema pallidum immobilization, also we use this Nicole strain. Okay. So there are also some ELISA kits which are available. So we can also use that. Okay. So this enzyme immunoassay. So what do you see the sensitivity and specificity of the percentage of primary, secondary, and in the late stages? So what are the specific and non-specific tests which are positive? If you see the non-specific test, it will be more seen in the secondary stages. Both non-specific and specific, in the secondary stages, patient will be more positive. Okay, so this is a very difficult stage where we pick up, and here also it will be the patient sensitivity will be much more than in the other stages. So it's very difficult to pick up in the primary stage of syphilis. So if you see this biological false positive, so it can be seen in acute infectious diseases like your measles, infectious mononucleosis, so mycoplasma pneumoniae, malaria, other like vaccinations. And in case of chronic infections like leprosy, then SLE, and this collagen vascular diseases. So these are the other conditions. So how do you routinely screen this syphilis? So if there is a lesion, first thing what we do is we just take the If you see the lesions, then you have to do the dark field microscopy. If it is negative, then we go for the VDRL or RPR test. So if the VDRL and RPR test is non-reactive, then we can tell it as negative. But it is reactive, then we have to do the other specific test, that is fluorescent treponema pallidum antibody absorption test. Okay, and then we have to report it. Otherwise, it will be a false positive reaction. So how do you treat syphilis? So treatment of syphilis is basically we use penicillin, which is a major drug of choice, or you can also use doxycycline, which is given twice a day for 15 days. So now we'll be seeing about Borrelia. So Borrelia, so it differs from other spirochetes, which is being larger, and it is wider and it has open coils. And they are the gram negative motile, and it stains readily since it is much larger. So it causes relapsing fever and Lyme's disease. This is Borrelia burgdorferi. So there are two forms of relapsing fever, that is endemic, that is louse-borne, sorry for the mistake, and endemic or tick-borne fever, which is caused more than 15 species of Borrelia. So if you see relapsing fever, it's febrile and it's a septicemic illness. The Borrelia recurrentis, it's a sole agent for this endemic or louse-borne relapsing fever. It spreads person to person, so basically by the body louse. So it is transmitted to the human by the infected, from infected person. It endemic or it's usually by tick-borne, okay? And the host can be rodents or other mammals. So the ixoid tick is a main cause of Lyme's disease. So Vincent's angina is usually caused by Borrelia vincenti. One second. So if you see the Borrelia, it has it can be grown in the serum, blood, or tissue, or any enriched medium. So the Gucci's medium is a medium which is used, which contains ascitic fluid and rabbit kidney, which can also be cultivated in the chorioallantoic membrane of chick embryo and intraperitoneal cavity of rat and mice. If you see the Vincent's angina, your incubation period is about 3 to 10 days, and the onset of illness is there can be fever. Okay. So this is typical of that of relapsing fever, and it is almost indistinguishable. So what are the lab diagnoses? What do we do? So either you can do a direct dark field microscopy. So Giemsa stain, it can be thick and thin film, then Leishman stain. So serologically, blood cultures can also be done. Serological test, what we can do is VDRL test can be done. So here, animal inoculation, it was used earlier. Treatment is by erythromycin, penicillin, and tetracycline. So next coming to Lyme's disease. So it is transmitted by exotic tick. Okay. So its a morphology is about it's flexible, helical, and it's a gram-negative organism. So here, so what will happen in Lyme's disease is this Borrelia burgdorferi, that it has a lipopolysaccharide cell wall. So the incubation period also it is around 3 to 30 days. So there can be one or more skin lesion which develop at the tick bite. Then after that it reaches the bloodstream. So if left untreated, what it can result in late manifestation, neurological or cardiologic involvement. And then sometimes a patient can end up with arthritis. So this is a Lyme's disease rash. So there are two stages here. It can be an early stage. There can be erythema migrans. So malaise, severe fatigue, headache, fever, chills, lymphadenopathy, and myalgia. And it lasts for an average of about 4 weeks. And in the later stage, there can be neurological or cardiological involvement, and there can be arthritis. So lab diagnosis it can be by the smear, like the from the blood by Wright stain and Giemsa stain, and so it can be also detected by culture of the blood, and then ELISA or immunofluorescent staining can be done. So treatment is with doxycycline and amoxicillin and erythromycin. So these are the drug of choice. And in the later stage, there can be, you can give ceftriaxone, parenteral ceftriaxone can be given. Okay. So, so here in this session, we just saw about syphilis and spirochetes. In that, the major spirochete which causes infection will be the syphilis. So, syphilis, it is a major venereal disease. So, there are various stages of syphilis, that is primary, secondary, and latent and tertiary stage. And then the most important modality for diagnosis of syphilis will be by the serological test. Okay, so we have a specific test and non-specific test. So specific test, we have to we have FTABS, treponema pallidum immobilization test, then fluorescent treponema pallidum antibody absorption test. Then other non-specific test is VDRL and RPR. So commonly used test. Okay, and these are the other treponem which causes some diseases. So we have just listed out. So this is about today's class. Thank you.